Good afternoon, everyone. Okay, good afternoon and welcome to the second webinar series for Secure. And this time, the focus is on women as part of ADB's celebration of International Women's Month. And we will have everything talking about women's voices, women's issues on vaccine and vaccine development, but down to vaccine deployment. We have a lineup of experts who would be providing their insights, and hopefully we'll have a very substantive interaction. And to start with, I'd like to introduce to you the project officer for Secure, Dr. Eduardo Banson. He's the principal health specialist at the Asian Development Bank. And Dodo is a medical doctor who champions universal health coverage and has long provided technical support to countries in Asia and the Pacific in their pursuit of UHC. Previously, he was the president and chief executive officer of the Philippine Health Insurance Corporation, or PhilHealth, and he was also with the World Health Organization as a regional advisor for health financing in the Eastern Mediterranean region. And Dodo is also a former World Bank senior health specialist. So please let us welcome Dodo Banson. Dodo?
Thank you, Randy, and thank you to our panelists, to Samahang. It's really great for us to work with the gender thematic group, and we look forward towards more collaboration. And of course, to our other panelists, right later we'll be talking about the gender aspects of vaccination. The Secure TA is surge TA to support developing member countries in Southeast Asia implement COVID-19 vaccination, design and implement health security interventions. We are now living in a world of climate change, in a world where we don't know when the next pandemic would be. So we need our countries to be ready, but more than ready, they need to be ready in a way in which they address the concerns of women, that they should be gender responsive. We also want to make sure that when they implement interventions, the pandemic is still there. It's not as bad as it was 2 years ago, that the implementation and in the response to pandemic, particularly vaccination, we also take all of these considerations to make sure that vulnerable populations, women, children are all being addressed. So I'm now excited to listen to all of our great presenters. So Randy, please, you could have the floor.
Thanks, Dodo. And to open our webinar for today is our director, Ms. Ayako Inagi, Director of the Southeast Asia Department Human and Social Development Division. She leads the planning, implementation, and supervision of ADB's lending and non-lending operations in the social sectors that includes education and skills development, health and social protection. Ms. Inagi is also the chair of ADB's Health Sector Group, where she guides the preparation and implementation of the Health Sector Group work plan. Ms. Ayako, over to you.
Thank you very much, Randy, and dear participants and Sam. This is really a great pleasure, to welcome you for the Secure Webinar Series 2, which is a fitting conclusion to ADB's months-long celebration of Women's Month and gender equality. So as the world tries to attempt to normalize living with COVID-19, and re-evaluate health security measures to prevent and be able to manage the future pandemics, we raise questions on how women and other vulnerable groups are factored in the development, planning, and implementation of COVID-19 responses, particularly in vaccine development and deployment. So today's webinar, Making Women's Challenge and Role in the COVID-19 Vaccination Program Visible, brings together distinguished experts, scholars, and practitioners to talk about the gender dimension in the implementation of COVID-19 vaccination programs, and hopefully to help inform and strengthen equitable vaccination initiatives within the Southeast Asia regions and also elsewhere. So I hope that this webinar will serve as an effective platform to help initiate raising questions and sustain a discourse in getting women, and that for the matter, other vulnerable groups to participate and the issues integrated in all aspects of COVID-19 vaccine development and deployment, and from the research and clinical testing stage to the crafting of vaccine communication, to the planning for vaccine mobilization, up to the monitoring of post-vaccine side effects and adverse effects after immunization. So we hope to have a rich discussion. So welcome again and wish you a fruitful webinar as we end the International Women's Month. Thank you very much.
Thank you, Ayako, for those words. And so we start the webinar proper, and to share with us the ADB's general overall gender framework is Ms. Samantha Hong. She's the Chief of Gender Equality Thematic Group at the ADB, where she provides leadership for advancing gender equality across all aspects of ADB operations and knowledge work. Ms. Samantha has over 2 decades of experience in gender equality at project, program, and policy levels in the Asia Pacific. Before joining ADB in 2009, she held various gender advisor roles, including for the New Zealand Agency for International Development, Pacific Islands Forum Secretariat, UNICEF, Australian Government Office on the Status of Women, and UK Institute of Development Studies attached to the University of Sussex. Samantha, your turn.
Thank you very much, Randy, for that very kind introduction. And it's a real pleasure to be here today. As everyone's mentioned, today is the last day, the 31st of March, and it's a pleasure to be here with you to conclude the program we've had for Gender Month. So what I would like to do in the next 5 minutes or so is just really walk you through ADB's approach to mainstreaming gender equality and women's empowerment in our work. And then it will provide a nice segue for the conversation you're going to be having about vaccines in particular. So if I could please move to the next slide. So the Asian Development Bank, under its current corporate strategy, it recognizes accelerating gender equality as the second priority. And it really sees that gender equality and women's empowerment is central to all aspects of development in the region. And so how we see it is we have 5 strategic operational priorities, or pillars, if you like, that are listed there on the slide. And you can see in what we're talking about today, it mostly fits under the second one, gender equality and human development, because we're talking about health under that pillar. But it also, women's health status and access to vaccines and the whole COVID pandemic also intersects with some of these other areas. We've seen women's economic participation significantly impacted by the pandemic and the lockdowns, for example, and women's role in the health sector and the employment sector also relates to their economic status. But it's also important to think about women's leadership and decision-making in all sectors, including in the health sector, and how they can contribute to better outcomes. If I could just move quickly to the next slide. So what's new in terms of our approach and the way we work is we really adopt a gender mainstreaming approach, which means that we look at gender analysis across all the sectors we work in, and obviously health being one of them. And we also, that applies also to our public sector operations as well as our private sector operations. But what's significant about our current corporate plan is that we have quite ambitious gender targets, gender mainstreaming targets, and they're listed in red there on the bottom right, that by the end of 2030, we aim that 75% of everything we do in terms of the number of projects will be directly supporting gender equality. And we also have a corresponding target that for those projects that have concrete plans around gender, what we call gender action plans, 80% of them will deliver what they intended by 2024. And how we do that is really having clear outcomes and targets in our design of projects. But also what's important is that we increasingly focus on some of the transformative gender agenda that are espoused in Sustainable Development Goal 5, which is that sort of graphic that you have on the left of the screen. And these are some of the transformative issues that really underpin gender inequalities, such as women's sexual and reproductive health rights, their unpaid work burden, gender-based violence. And actually in the pandemic context, we have seen some of these issues become increasingly under the spotlight. They were always there, but they've become exacerbated by the pandemic. On the next slide, just very quickly, how we approach this, if we could just move on to the next slide, is we are actually quite well respected as a multilateral development bank in the way that we mainstream gender. We've had a policy in place since 1998, so we were actually one of the leaders. And so our current strategy builds on that. And the way we do it is that we have a 4-tier system by which we screen all our projects, and we determine the extent to which or how strong their gender designs are, and we categorize them by one of those 4 elements. And that means that we that builds in a quality assurance system within the bank, and it also means that we build capacity along with the way we implement when working with government and private sector clients. So in the next slide, really just to say that in a COVID recovery, a COVID response and recovery pandemic, I think it's well known that gender issues have really been put at risk because of long periods of lockdown, the etc. So we see that building back forward, even more important to place on gender equality, making sure that whatever project we do, including in the health and vaccination sector, are really intentionally addressing gender issues and really understanding some of the underlying issues gender equality to be realized. So just on the last slide, this is my last one here, really in terms of vaccine access, ADB has been supporting quite a lot of vaccine access programs, what we call our AppVax facility. And through that, we recognize that there are some specific gender challenges with regards to vaccine access and delivery. And I'm sure this will be spoken about by the other speakers, and I won't go into much detail, but just to say that we've seen in some research that we are actually supporting with UN Women and rolling out their rapid COVID gender impact surveys in several countries across Asia Pacific, that we are actually seeing that there are gender differences in terms of women's access, their availability due to different norms, and also fear of side effects, particularly around women that may be pregnant. And these side effects and these kinds of issues are actually keeping women from getting the vaccines that they should. So it's really important that when we design vaccine interventions, we look at it holistically in terms of the information systems, that we make sure that we have the disaggregated data, we generate the demand amongst groups that may be mobilized. We are conscious of gender sensitivity in the way the service is delivered, the way we survey in terms of the numbers, and we keep track of the data, and that we raise awareness amongst the community, amongst groups that may not be accessing. And the last point is really, where possible, while we are rolling out COVID vaccines, we should also be thinking about other gender-specific vaccine needs, such as HPV. So I'll leave it at that. I know it was really rushed, but I want to leave time for everyone to go into this much more detail, and I look forward to the discussions. Thank you for inviting me.
Thank you, Samantha. Thank you so much. And as what Ayako said earlier on, this platform, this secure webinar, not only discusses issues on women and girls and other vulnerable groups, but also we will try to raise questions, and hopefully they could be addressed, they could be responded to as part of ADB's and all other development partners developing projects on vaccine and vaccine development and deployment. So for our next speakers, we have actually 2 speakers on gender dimensions in vaccination planning and mobilization. The first speaker is Ms. Jean Monroe. Jean is the Senior Manager for Gender Equality with Gavi, the Vaccine Alliance. She supports Gavi in implementing its revised gender policy, ensuring gender equality is mainstream in Gavi programs, and supporting countries to develop gender-responsive and transformative immunization initiatives. Jean has over 20 years of experience working in the area of gender equality, inclusion, and women's rights across numerous sectors. She has enjoyed living and working in Malawi, Ethiopia, Nigeria, and Vietnam with CSOs, the UN, and the Canadian government. Your turn, Jean.
Thank you very much, Randy. It's a real pleasure to be here, and thank you very much to ADB colleagues for the opportunity to speak with you today. Just please tell me if you're able to see my screen.
Yes, we can see
Yes.
it, Miss Jean.
Okay, and is it on a slideshow now?
Not yet from my screen.
Okay.
There you go.
Great. So what I'd like to actually start by just saying how wonderful it was to hear Samantha's description of the ADB's approach and the new policy and your very high targets that you've set. Gavi is a little bit further behind on implementing this gender policy. So it's wonderful to hear about other institutions who've really been working on this for a long time, and that you've integrated it extremely well in your programming approach. And I think, ADB is in a wonderful spot as well because you're working in so many different sectors. And I think that's a really effective way to gender mainstream is by looking across many sectors and not just focus on one. So today, what I would like to talk about is currently what we know about the impact of the pandemic and looking back as a reflection on how was programming done. And then to introduce some tools and processes that we at Gavi are promoting for our countries to use when they're designing their COVID-19 delivery. And some of the interventions that have come up with from communities that really can help reach women, and not just women, but address some of the gender equality barriers that we're seeing. And then I'll have some reflection on what to consider after the pandemic. So in terms of what do we know? The first thing I'd like to talk about is the current health system that has a very low representation of women in decision-making positions. What we've seen is that there's a direct link between the paucity of gender-sensitive measures and the lack of gender parity in decision-making. There was recently a study that looked at 87 countries, and they found that only 3.5 of the COVID-19 decision-making expert task forces had gender parity. So the global community was unprepared as COVID-19 struck. As a result, countries swiftly established experts, decision makers, primarily through traditional processes, such as reaching out to the government ministry directors, prominent experts, and heads of well-known institutions. And we know that most of those institutions are typically held by men. What these studies didn't look at was whether or not there were gender experts. So there are many men now who are gender experts and can raise issues around gender just as well as women, but still we need to work towards gender parity on these decision-making boards because of ensuring that women have their lived experience as part of the decision-making process. We also saw that there was very little disaggregated data on coverage rates by sex at the beginning of the pandemic. That is much better now. But particularly in Africa, it was very difficult to find this type of data. Those countries that were, however, able to report we did find that there was very differing coverage rates. And in many of the countries that we work in Africa, not so much in Asia, there was a lot more men being vaccinated than women. The other part is the vaccine hesitancy, and I'm very glad we'll hear a little bit more about that from other panelists today. But I think we were unprepared. We spent a lot of time trying to procure the right vaccines, making sure they got into countries and got out without looking at the social aspects of it. And this has had impact on whether or not there's high coverage rates of the COVID-19 vaccine, but it also has repercussions now on hesitancy around routine immunization. There was also top-down planning. Because of the rapid planning, there wasn't time, or people didn't take time to really understand the community's concerns. And that's created also a siloed approach. There wasn't an opportunity, or people didn't take the opportunity to really work across different sectors or even within the health structure to build on systems that are already working. Instead, a siloed approach was created in many countries to deliver the COVID-19 vaccine. And now that needs to be rethought, because we can't continue to have that, because it has a negative impact on how well our health systems are working. And the other aspect that we were unprepared for was the human resources needed. Again, many countries put a lot of effort on the more infrastructure, on getting the vaccines out, and less on the need to address the social aspects. So there's a number of tools and processes that are available that I suggest could have made quite a big difference if they had been systematically used, and if we use them systematically in our health systems planning now. So really, to understand the gender dimensions, I propose that a gender analysis framework be used, that we use a human-centered approach in our designing of immunization programming. And there's also a wonderful tool I'd like to introduce you to called the Journey to Immunization. And that, well, I'll show you what I mean by that. So these are 3 tools, processes, which I suggest could make a significant difference in the quality of our programming. The first is a gender analysis framework. And this supports the, this framework supports analyzing the collected information on gender differences around 5 different domains of the social life, with power as the cross-cutting of the 5 domains. It helps us to understand the multifaceted influences of gender-based social structures, the roles and norms which closely relate to individual demand for access to immunization and health services. So to increase immunization coverage and equity, gender must be explicitly considered as an integral part of the initial design, implementation, monitoring, and evaluation of immunization interventions and policies. Gender mainstreaming refers to the process of identifying and addressing gender inequalities and its impact on the development outcomes. Since gender norms, barriers, and gender roles influence how an activity is carried out and its impact, analyzing and attending to these issues is on an ongoing basis is essential. So gender analysis involves examination of many of these 5 different areas that are listed here. So we see at the top, we've got the roles and responsibilities of women, access to resources, beliefs and perceptions, needs and priorities, and institution laws and policies. And the analysis has specific questions to ask on all of those different aspects. When we've used a gender analysis, often you can see where the gaps are. If you're not able to find information on those specific areas, there could be a gap in your programming. So that's why this framework is really useful to really get the information, to raise the information, to help decision makers design a program that will address it. So just an example, on the top there we have roles and responsibilities. So in the vaccination space, we could ask who's responsible for deciding whether to be vaccinated? Whose role is it to arrange the logistics to be vaccinated, to take the family members for vaccination, to pay for the service or the transport, or to take care of the children who do not feel well after the vaccination? So these types of questions can be raised in a systematic way. What we've found is raising these questions, but using the journey to immunization is an important way to ensure that you understand the full process that usually a mother goes through in the immunization journey. So here, if you're not familiar with this, it's a 6 steps that one individual often takes when they're deciding about a vaccination. So the first is knowledge and awareness. Does the person even know that a vaccination is available or what it's actually for? The second, something we often overlook, is the intent. So this is about the negative attitude or fear of immunization not as a social norm, or lack of decision-making power perceived, and behavioral control. The third step is the preparation. What does an individual need to do to prepare for the vaccines? What's the cost that they will have to take care of? And what we do spend quite a bit of time on is the point of service. So what actually happens in the clinic or the vaccination service. And the sixth is after service. So the side effects, or whether or not questions were asked. So we found that this tool has been useful to understand what happens for the individual, for the family, and the health systems. And we not only look at it from a caregiver point of view, but we also look at it from the health worker's point of view, using this journey to immunization. So there's a new tool that's coming out, developed by UNICEF, which has tracked many of the gender barriers at these 6 points, and has also identified interventions that can respond to those barriers of those 6 points. And that will be launched in the next month or so. And I'd be happy to share that with ADB, because I think it'll be a very useful tool, not only to learn from interventions that are on the ground, but also to have, again, a systematic way of looking at the full immunization cycle. And finally, I'm sure ADB colleagues are very familiar with this, but within Gavi, we've just seen so many positive outcomes of using human-centered design. Essentially, human-centered design is putting the person, starting with the person's needs and experiences at the center of any problem discussion. So I would say with the COVID-19 delivery, we've spent a lot more time on focusing on the vaccine and getting the vaccine out, and less time on understanding the person who actually needs the vaccine. So switching the framework and using the human-centered design helps us do that. So here you'll see some of the discussions of a caregiver and some of the discussions or thinking points of a mother who, or an individual, in this case, when we're talking about COVID-19, who's seeking the vaccine, and all the different things that are going on in their heads. So we've recently just worked in Pakistan, developing their immunization program, and we use human-centered design. And we created a number of different personas of kind of typical people who would be bringing their children or seeking the COVID-19 vaccine for themselves. And this was creating a persona allowed everybody in the room to really understand what are the different barriers that a caregiver would have in trying to access the services. And then it also led to human-centered interventions that really meet the needs of individuals. And this was what we learned was it was actually a very easy way to bring out the gender dimensions. We didn't call it a gender analysis. We didn't have, so-called gender experts there, but the gender dimensions were so profound in the discussions that came up. So you may be aware in the MENA area, Save the Children, Common Thread, UNICEF, and Buzara came up with these little jab aids. And these are fantastic notebooks that have been developed that were used human-centered design and a gender analysis to, first of all, identify what the barriers were for individuals in accessing the COVID-19 vaccine, and then to come up with recommended interventions. So the process, first they came up with a little jab aid for women, and then a little jab aid for teachers in the area. And we will be working to develop one as well for healthcare workers. But it's now expanded, and last week they launched the little jab aid for Nepal, as well as one for Kenya. And so you'll see here, on the right-hand side is the overview of the Nepal booklet and a number of the challenges that came out. So in their process, they said some of the key challenges to vaccine uptake and confidence. Sorry, I'm not quite able to read here. Recommendations for people who are concerned about the side effects, looking for endorsement from religious leaders, prefer to wait until they're able to choose their vaccine brand, limited access to timely vaccination, uncertainty about the vaccination process, lack of confidence in the vaccine, and some implementation tips. So those are the main parts of the Nepal book. And then it's for each of those concerns that were raised, there's a number of different interventions that they're suggesting. So sharing trends towards vaccination, making information available about the side effects, bringing health services together, similar to what I mentioned at the beginning, leveraging local influencers, making vaccination a social event, and changing mental models about specific vaccine brands. So if we look beyond the pandemic, I think there's a number of things we can learn. First of all, as I've tried to point out, the use of human-centered design as a way to integrate services that meet the needs of individuals. We've just seen such positive results with this that I'd like to underscore it. Secondly is our need to integrate health services, particularly in the immunization space. We know we can be much more successful if we've integrated into other services that are well-known and trusted in communities. And the third is to put equal weight on the demand side of immunization programming as well as the supply side. And something that we'll talk a little bit later from our other panelists is the need to build on the opportunities that CSOs present. The pandemic really put a stress on our government services, and there are many CSOs who are well trusted in the communities that really understand the needs of their specific communities. And I think there was an opportunity that was overlooked to really work with CSOs to have a much more effective response in the pandemic. So with that, Randy, I'd like to turn it back to you, and thank you again to ADB colleagues for asking me to be part of this really interesting webinar. Thank you.
Thank you, Jean. Actually, we have already generated some questions, and which we will be discussing later on during the plenary session. One is coming from my good friend Najib. We'll be sharing the questions later on. And thanks again, Jean, for the tips and the tools that we find useful for our gender work. And to complete this session is another expert. She's Dr. Lavanya Vijayasingham, an interdisciplinary global health research professional from Malaysia. Lavanya's just completed her doctoral fellowship at the United Nations University International Institute for Global Health, where she worked on gender and health policy, programming, and research, including on the integration of sex and gender factors in COVID-19 research and development, regulation and monitoring, and in national vaccine deployment programs. Lavanya has prior experience in academia, government, the pharmaceutical industry, consulting and NGO settings in Australia and Malaysia, and is a self-proclaimed health for all idealist who is keen to continue this advocacy and research in her future global health work. Lavanya, your floor.
Thank you so much, Randy. I just want to confirm that you can see my slides in full screen.
Yeah, we can.
Thank you so much. So once again, thank you so much for this opportunity and for inviting me to share some of my work that was done as a postdoctoral fellow at the United Nations University International Institute for Global Health, which is the United Nations think tank for global health in Kuala Lumpur, Malaysia. So today, as Randy said, I'm going to speak briefly about the sex factors in COVID-19 vaccines, R&D, regulations, and real-world outcomes. So my esteemed colleague, Ms. Jean here, just spoke about gender mainstreaming in delivery and the gender-related social and structural factors that influence vaccine access and uptake. This also relates to how other health opportunities, actions, and behaviors and manifest across different settings. So I'm now going to move the discussion away from gender in the social domain to sex in the biological domain. That is sex factors contained within the body. So here I'm referring to all biological differences beyond just the reproductive systems. That is the genetic, cellular, biochemical, physiological, and immunological aspects and differences. So I just want to say here that, of course, there's going to be overlaps, and there's not always clear distinctions. So for instance, we knew early in the COVID-19 pandemic that men were more prone to complications, severe infections, and death. But the possible reasons to explain this included both biological sex differences in immunity and biochemical aspects of the infection process, as well as broad gender-related issues, such as hand washing, for instance. So I acknowledge that there are overlaps, but for this talk, let's focus on the biology. So another point that I want to state clearly before moving ahead is that biological sex considerations in disease and interventions like vaccine outcomes relate to everyone, and that sex, like gender, is also non-binary in the biological sex profiles of intersex and gender diverse individuals. This also should be considered. But there is a history, or if you may, a legacy of male bias in broad medical R&D that is unfortunately not completely resolved in this day and age. So making sure that women and girls are able to use safe and effective medicines all through their lives is not only about the financing and access systems, it's also about product research and development and regulations and real world outcome monitoring. And so given today's topic, I will first focus on the broad status quo of R&D, that is the gaps in addressing the nuances of women's biology and its perpetration through the COVID-19 vaccine R&D process, which also has not done very well in prioritizing and addressing women's experiences and concerns. I will then end with some suggestions and approaches that stakeholders such as regulators, funders, and networks of scientists can advocate for, adopt, and enforce. And I end by floating an idea that for regional leadership to move action on this agenda forward. So very simply, women and men, we are biologically different. Our bodies are different in terms of composition, size, biochemistry, functions, etc. This also means that there are differences in disease risks, symptoms, clinical signs, and levels of severity. These biological sex differences also affect how interventions like vaccines, pharmaceuticals interact with the bodies, that is, its rates of absorption, movement through the body, and importantly, the levels of outcomes it can induce. So what this means is that there is a potential for these sex differences to influence the safety and trial-based efficacy and the real-world effectiveness of products to various extents, that can be clinically meaningful and for policy and practice. So by not paying attention or adequately addressing these factors, the R&D community risks perpetuating harm and unmet needs for women, such as limiting timely access to these life-saving and quality of life improving choices and their right to good health. So maybe this information is not mainstream enough, that it's not deemed important, but the female body, women, have been historically excluded from R&D in the medical sort of landscape. And even these days, we are still underserved. So reasons that have previously been used to explain this include safety and precautionary ethics, the complexity of considering the variations of hormonal cycles, the costs of additional research, and women's own refusal to participate in research. So across the R&D and regulation and post-market sort of continuum, there's still insufficient considerations, analysis, and reporting of sex factors. So in the preclinical stage, even as late as 2016, up to about 70% of biomedical experiments still did not include sex as a variable of interest. And half of these studies included both male and female animals as part of the study sample. In clinical trials, while we are doing better over the years in representing women, but the problem right now is that we lack representation from different groups of women at different stages of life, such as older women, pregnant and lactating women, women from LMICs and different ethnic backgrounds. So interestingly enough, global vaccine trials have more women participants, but then again, representation of different groups of women are still lagging. In regulations, regulators in the US, Canada, and Europe have policies calling for representation, consideration, analysis, and reporting. But the problem here, and on most days, is enforcement. At the post-market stage, broadly speaking, women tend to report more adverse events that require medical attention, while men experience more serious and fatal events. That there are studies that now are exploring and suggesting that the connection between these observations is the under consideration of sex factors during the early dosing studies. So this is the broad status quo. And so how did things change during COVID-19 R&D? Well, this is a very short story. It didn't change. There were very early calls to pay attention to gender considerations, but this was not well picked up on by the R&D community and the global agendas, even when there were clear prior policies in some instances, such as the commitments from journal editors and policies from funders and regulators. So this took the proverbial backseat. In the first year of vaccine studies specifically, only about a quarter of reports reported sex disaggregated outcomes, and less than 15% discussed any sex considerations at all. And of note that there were global guidance on and decision-making stakeholders that produced evaluation guidelines, but again, these also did not require or call for disaggregation of safety data in particular in the early trials. So why is this an issue? Why does it matter? So I talked about how sex differences are prevalent across many aspects of human biology, but sex differences in immunity and immune response, as well as in vaccine outcomes, have been well documented in our scientific scholarship. Across multiple vaccine areas, women tend to mount a higher immune response to the same dose received by men. Women also tend to report more adverse events across multiple vaccine areas. We also know that there are sex-specific differences in outcomes across the life course in children, in post-puberty teenagers and adults, in pregnant and lactating women, postmenopausal women, and older women. So I'm really speeding through here, trying to give you the top line points, but I'm trying to point you to the body of scholarship that provides a strong case for the better integration of sex and gender factors in R&D plans and product design and decision-making. So what we are observing with COVID-19 vaccines now adds to this existing knowledge on sex differences in outcomes. In the early days, while very rare, the reports of blood clots seem to be women disproportionate, and now the incidence of cardiac complications is men disproportionate. So post-market surveillance data, mainly from the US, now suggests that women also tend to report more adverse events, but serious adverse events appear to be more prevalent in older men. And of course, there are further intersectional considerations that need to be explored further, such as the relationship with ethnicity, frailty, concomitant medicine use, and comorbidities, and that sort of thing. So of course, another challenge is that women's concerns, specific needs, and experiences were not well factored into the R&D plans. So this is where the connection between R&D, regulation, real-world outcomes tie in with engagement with the populations who use the products, science communications, and then of course, responsive actions that address these concerns to build trust and promote uptake of interventions. So once again, pregnant women were not included in the early trials. And this is usual practice, some may say, but the status quo was not disrupted despite, number one, past lessons from Ebola crisis, where women who were also at higher risk but were left out of trials, and subsequently vaccine delivery programs resulted in some preventable deaths, unfortunately. And secondly, we had very early knowledge that pregnant women were at higher risk of COVID-19 complications, but yet, still did not choose to act from that knowledge. And much of the early data on the use of vaccines amongst pregnant women came from post-market safety surveillance from the pregnant frontliners, mainly from high-income countries. I'll add here that women were also concerned about many other aspects of safety, including on their fertility and menstrual changes. A lot of these concerns came from various sources of historic issues that were not considered early enough in the R&D and science communication plans. In terms of menstrual changes, women across the globe shared similar experiences through social media, and research in the form of global surveys were mobilized to document and analyze the prevalence of these experiences. Preprints of these studies are now beginning to be shared publicly ahead of peer review. And these reveal, something up to 40% of usually menstruating women temporarily experienced heavier bleeding, and about 65% of women who do not regular menstruate, that is those on long-acting contraception and those who are postmenopausal, they've experienced breakthrough bleeding. And so now, in the event and in the light of this data, regulatory agencies like the European Medicines Authorities are now paying attention to these concerns and calling for further reviews and assessments of these influences. So how do we do better? How do we learn from everything that has unfolded? So for COVID-19 vaccines, it's still not too late. As of today, I checked in the morning, it was 15% of people in low-income countries have received their first dose of vaccines. And globally, we're still talking about multiple rounds of boosters. So answering these questions and addressing these unmet needs for data is still important, and will importantly also shape the future for more sex-responsive R&D practices. So with the existing options and all vaccines in the development pipeline, especially those led by colleagues in the Global South, at a minimum, analyze and report the sex disaggregated data and mobilize efforts to study and answer these remaining questions. So in terms of regulatory levers and real world data, so number one, for the regulatory processes, we can really benefit from consistent requests for sex disaggregated data on safety and efficacy. For instance, rolling reviews or retrospective calls for evidence is one of the possible ways to obtain and act on sex factors in R&D. So this can be done by negotiating a timeline of sorts for the delivery of this data and analysis, using incentives and penalties to drive actions. Post-market processes, well, age and sex disaggregated data is already called upon for by the WHO Safety Surveillance Manual. And the point here is to ensure implementation, enforcement, and investing in sustainable infrastructure and processes that can promote long-term and real-time access to this data. So what I'm saying, a lot of the points that I'm talking about here has been called upon through this checklist, which is a guidance document that was jointly created and published by the United Nations University and the SDG 3 Gender Equality Working Group that includes UN and multilateral agencies like Gavi, the World Bank, UNDP, UN Women, and WHO. So I invite you to refer to this document for discussions on how both sex and gender barriers can be addressed further. So this is my last slide, and I just want to end by floating this idea or opportunity for regional action, push, and leadership to course correct. So if you take one message from me today, please let it be this call for joint action from stakeholders to champion better sex-responsive R&D practices within your own teams, scientist peers, and in your own capacity as influential stakeholders in vaccine R&D, regulation, and real-world monitoring. So why is this important? What's the value in doing this? Well, for one, it's just better, more rigorous, and more precise science that provides stronger evidence to inform policy and practice. And number two, it leads to better innovation, market advantage in some instances, and it serves unmet needs in the market, health systems, and society that can then contribute to human capital gains in economies and facilitate a more gender equal society. And lastly, what are the specific actions that we're calling for? Number one, as a minimum, analysis and report of sex disaggregated outcomes. Even when there's no differences revealed or there is low power, reporting and sharing information adds to our body of knowledge. Number two, when drawing up R&D plans, including for ethics approval and for funding applications, please include a short description of how sex factors could potentially influence outcomes, or conversely, why there's no expectation for outcomes to be influenced by sex factors. Number three, engage in dialogue to shape joint actions. Number one, with different groups of women, in this case, and number two, with groups of stakeholders, especially those who may not be convinced of the value and rationale just yet. Number four, use the regulatory levers that you have access to and as incentives and penalties to shift practice and consistently enforce the requirements to build up a habit. And number five, lastly, invest in strengthening data systems in general to support real-time visibility and response towards real-world safety and effectiveness data. So I'll end there, and thank you so much once again for the opportunity to share this research.
Thank you, Lavanya. Thank you so much. And we can see the gaps now in as far as gender and women's issues are concerned, from planning to the research and development to clinical testing and so forth and so on. And next, this was mentioned earlier by Jean, we'll be talking about vaccine hesitancy. And our speaker, Dr. Kenneth Hartigan Go, is an internist, toxicologist by training, and served previously at the UP College of Medicine Department of Pharmacology as a professor. He was Undersecretary in the Philippines Department of Health and Director General of the Food and Drug Administration. He previously sat as a member of the WHO Advisory Committee on the Safety of Medical Products and the Global Advisory Committee on Vaccine Safety. He is also a member of the Scientific Advisory Committee on COVAX No-Fault Compensation for Vaccine Injury. Dr. Kenneth, the floor is yours.
Thank you very much, Randy. And I'd like to thank Asian Development Bank for their leadership in initiating such activity today. I'll present my slides. Okay. My talk today is about vaccine hesitancy. We were very intrigued when the Philippines did a study through the Social Weather Station, an online survey that shows from April to May 2021, the breakdown of vaccine acceptance and hesitancy. And this was reported by the Behavioral Insight Network of the Philippines. So we were shocked to find out that 32% of adult Filipinos are willing to get their vaccine, and with a colatilia that's provided for free. And a third is unwilling to even get vaccinated. 35% is uncertain about getting vaccines, and because of being scared of its adverse effects, being novel vaccines. Now, according to Asia Pacific Immunization Coalition, published in January this year, there are many factors that influence hesitancy. Number one, the trust in the vaccine. And we know that this is a novel vaccine, but one has to equate that with relevance to the existing pandemic. Its efficacy and safety profile is relatively unknown by the time. No? But an important thing that came out also is the level of trust in the technology is equated to the level of trust with the government and the current service delivery. And therefore, and later on, we will show that the confidence in healthcare professionals and healthcare worker is a determinant of vaccine confidence. Last but not least, the important aspect of the accountability of social media posts. As we know, there has been quite a bit of disinformation and misinformation that creates a confusion in accepting this new technology. A study was done through the Ateneo University School of Government, in particular, where I belong, and the credit goes to my co-authors, Ronald Mendoza, Dr. Madeline Ong, and Jural Yap, our statistician, where we did a study looking at the multi-wave patterns. And the research question that we were asking were this: what are the determinants of vaccine hesitancy? And secondly, what can we learn from here that would offer insights to help policymakers, decision makers, into creating a tailored fit, targeted communication strategy? Excuse me. So the methodology called for us to collect data from MIT Facebook through a digital economy arrangement between the periods of July 2020 to March 2021. But mind you, in many of these countries, vaccine wasn't really made available yet. So there were a lot of talks about this new vaccine coming in up to the time that the vaccine was rolled out, no, in the first quarter of 2021. We decided on 5 Southeast Asian countries. Logistic regression was undertaken through the survey data. And we pegged the significance level, the findings that we will show you, between 1% to 5%. However, we acknowledge that there are sampling bias in this methodology. For instance, groups that have no access to internet would therefore not be considered in the study. So please bear that in mind. We need to also anchor the definition of vaccine hesitancy, and because there are many different perspectives, no? So we followed again the Asia Pacific Immunization Coalition by borrowing their paradigm. So vaccine hesitancy is confined to those groups that are unsure and refuse the vaccine, unsure and delaying the intake of vaccine, and unsure but will accept later on. If you were to look at the demographic profile of a respondent in the survey study, so they're almost the same with subtle differences. No, male and female gender differences are indicated in these numbers here, with Philippines dominating with more females. But with the age group, you will see that we collected more data from the younger generation from Vietnam and covering more elderly population up to 50 years old in Thailand. This particular slide shows out through the 5 different Southeast Asian countries and their time series where we have up and down on vaccine hesitancy. What this actually tells us is initially Indonesia and Philippines has the highest vaccine hesitancy, but these numbers then eventually change later on. So I'm going now to go to the summary of the results of our study here. The highest vaccine hesitancy is found in Indonesia in 42% of their population, followed by Philippines, the second highest, with Malaysia trailing behind at 27. Now, mind you, this is the initial part, no, of when we did the study, but these numbers have changed later on. There were also other countries, no, where most COVID cases per million population were considered here. Vietnam has the highest respect and rating for government on community management of COVID. And this was explained as leading them to higher confidence in vaccination. Well, you find the opposite for the Philippines. And this was something that we found. No? With respect to age, the older generation and population and respondents rather from Malaysia and from Thailand are likely to be vaccine hesitant. However, in the Philippines, older population among our respondents are less vaccine resistant. So that means they have trust in the vaccine as you get older. But there is also an interesting finding. No? There's a socio-economic class difference. For instance, in the Philippines, the poor seems to be more vaccine resistant and hesitant than compared to the upper rich segment of our population. Now, here comes a very interesting thing that we didn't expect, and it's highlighted here in the red font: gender differences. It appears that women in the Philippines, and that 56% reported, are vaccine hesitant. However, in Indonesia, trailing behind is 52%, Malaysia at 42%. No? Later on, as we find the wave changing towards the end, Thailand was catching up with women becoming more vaccine hesitant. And maybe we can go to some speculations and based on some literature and experience, but this wasn't really the objective of our study. We didn't know what was going on, but let me postulate some hypotheses. Mothers or would-be mothers are unsure whether to get the COVID vaccine, and this is due to their perception of medical research, the lack of medical research covering their gender. No? And our previous speaker has eloquently explained that in the R&D clinical trial, oftentimes pregnant women in particular, in general, are excluded from the study. Apologies. Sorry, I touched on something. Okay, now why women? According to The Guardian, an article that was published in 2021, and this was largely findings and observation coming from Australia, women in this age bracket of 30 to 40, and you can see that our respondents were in this age bracket when we did this survey, they are likely to be pregnant and would be going to pregnancy, they have breastfeeding concern, or are raising a young family. So you could expect that in this age group, it is natural for them to be worried with getting a vaccine that is novel, where data is not yet uh, full in terms of research in clinical trial. We also postulated that maybe because healthcare responsibility is largely given to women and largely feminized, and because of this, they are the ones making the decision and they tend to be more careful. The study period for pre-vaccination, pre-March of 2021, caution was made at that time in many countries for those who are pregnant. uh, don't take the vaccine yet because of lack of safety data. But this was eventually subsequently changed when many of our obstetrics and gynecology society experts have come forward and says, look, data seems to show that it's okay to give it to pregnant women. Our earlier speaker also informed us that the lack of knowledge on how the complex women's biology work, and this might also explain the hesitancy there. And trust gap, the trust gap to health system, for instance, being excluded from research, scientists not knowing the answers to questions, and doctors not giving that kind of advice that reassures women, would largely contribute to vaccine hesitancy. Some of the theories that we also want to postulate, and I will focus on two countries, not the Philippines. There seems to be some evidence locally of targeted misinformation and fear mongering for women. And there's an article and a number of articles written in public domain that one could see that Dengvaxia, the situation that came out in 2018, and with targeting women population to tell them about the harm that can happen, led to general vaccine hesitancy from previous 93% vaccine confidence that has dropped to 32%, no, within a period of 5 years. In Indonesia, for instance, there were cited issues like, well, our vaccines have to be halal certified, and we are concerned that it may contain certain porcine components, We don't trust the sources of vaccine in some countries because of the links to communism, the coercion that government has imposed through threats of fine for not taking on the vaccine could also lead to population rejecting a vaccine and therefore mistrust in government because of unclear messaging and the belief that this is a new vaccine and we're giving it to normal people with no medical illness, while alternative preventive methods are available, makes them decide not to take the vaccine. If I were to go further and show the interesting social determinant results, television. This is a top-rated medium, and curiously, television in Indonesia helped in diminishing vaccine hesitancy, but curiously in the Philippines, it increased the hesitancy. And this is something that is worth researching further. No? But the newspaper, another news platform, is different. No? The trust in newspaper reports help drive vaccine hesitancy downwards only in the Philippines. So you can see how the medium may be very different. No? And who are the audience of this particular social media. Radio is very pervasive, ubiquitous in many of the countries. And in the case of Vietnam, trust in radio is linked to decreased vaccine hesitancy. But they only found that in Vietnam. Journalists in general, in Thailand, the trust in journalists seems to bring down vaccine hesitancy, but not seen in other countries. Now, the next part is very important. World Health Organization as an international health organization, local health worker, and scientists, they command the highest trust in general. Trust in scientists in the Philippines, for example, lowers vaccine hesitancy, and this is a good thing. And therefore, we need to develop them further, giving them communication skills so that they are able to translate this further and make it more colloquial. The trust in local health workers work very well in Indonesia in lowering hesitancy. So don't discount the people working in the field, no, for bringing that vaccine confidence up. And this is something that also came out interestingly because in this pandemic, politicians, government authorities are in the forefront of giving information and creating the strategies and articulating it. However, generally in all those 5 Southeast Asian countries, they command the lowest trust in general. Going further into the results, it seems that if one has more information about COVID, it is linked to decreasing vaccine hesitancy in countries like Indonesia, Malaysia, Philippines, and Thailand. And this is a good thing. That means information builds trust and some level of credibility. The appetite for information is rather important because increased appetite for information has links in decreasing vaccine hesitancy seen in these 2 countries, Indonesia and in Vietnam. So coming down to the last part, across the 5 Asian countries, respondents who know of somebody who had illness and tested positive for COVID, they tend to be less vaccine hesitant. And probably we ascribe this to a level of reality and fear. Wearing masks, this is an interesting phenomenon. Those who wear masks and view masks as effective are less likely to be vaccine hesitant, as seen in these 3 countries. Hand washing in the Philippines. Hand washing is another social determinant linked to decreased vaccine hesitancy. Governments. We have strong evidence linking increased satisfaction to how the country pandemic response is being managed by the country. You know? In the Malaysia, for instance, we saw that there is less vaccine hesitancy because of trust in government. So if the trust in government is high, this will result in lower vaccine hesitancy in Indonesia, Malaysia, and in Vietnam. In the Philippines, however, sad to say, the low satisfaction to how the country pandemic response is being managed have contributed to vaccine hesitancy. Some of the consideration in coming to a conclusion. We believe in medical sociology that ineffective communication can contribute to lack of confidence. The need to reinforce trust in certain personalities like journalists, scientists, and credible clinicians and doctors who are good sources of information how regular should they be out there, and what quantity of information that is laymanized is important. During crisis, we also note that government managers needed to bring trusted media practitioners and to level off the basic science. And in what way? In doing factual sharing of information rather than giving opinions and editorializing the content, because this adds to the confusion if they were to give their own subjective perspective. This is something that we thought is important for government authorities to consider. Monitoring proactively misinformation might help address the budding information going out there in the social media or airwaves. For instance, there are groups promoting alternative cures and prevention without a factual basis in science. This should have been nipped in the bud, no, earlier. A better understanding of the behavior of people and society will create a more custom fit social marketing practice in terms of fine tuning that information that we share. I'd like to share that scientists, while you are the most trusted people out there, according to survey, sometimes they don't agree on the details of science and in their own interpretation. My only advice is they have to be prevented from arguing in the public space, especially in the social media, because that leads to the level of confusion and mistrust. Okay. The other important thing, and our previous speakers have eloquently mentioned this as well, the importance in capturing and addressing adverse event following immunization, providing quick, good feedback, because people will tend to think that there's a conspiracy of hiding something, no? And this is something that can be really addressed moving forward. This is a slide showing the uptake of vaccines in different countries, but it would be difficult to ascribe this to improving vaccine confidence, because another level of consideration here is the way vaccine logistics is being undertaken. In conclusion, and my last slide here, I'd like to share with everybody, trust in government and the health systems will influence the trust in the technology called the vaccines and in the way vaccination is undertaken. And therefore, there has to be targeted, effective communication strategy. A whole of nation approach is necessary by engaging multi-sector stakeholder participation, creating shared participation and ownership of the problem. I think community is knowledgeable now to be looped in into shared decision making, and governments and scientists needs to amplify correct message by working with trusted media practitioner. So back to you now, Randy, and thank you for this time that you've allotted for me to share the results of our finding. Thank you.
Thank you, Kenneth. It's becoming more interesting. There are a lot more issues that actually need to be discussed, and I think we would need several webinars, no, to tackle the issues that you raised, particularly on vaccine hesitancy, why there are more women than men in the Philippines, and the type of communication messaging that should be planned and programmed to address this hesitancy. And the next speaker will actually look into the community hold on, vaccine communication and community engagement. It's a very nice segue to what Kenneth just discussed. No, Dr. Beverly Lorraine Hall, Bev, is a medical doctor who is the concurrent director for Health Promotion Bureau and for Disease Prevention and Control Bureau at the Department of Health, Philippines. As Health Promotion Bureau Director, she leads risk communication and community engagement and demand generation for COVID-19 vaccines. Prior to this, he was Chief of Research Division of the Health Policy Development and Planning Bureau, where her efforts significantly contributed to the passage of key legislation on sugar-sweetened beverage tax, tobacco tax, and universal health care. Bev, the floor is yours.
Thank you very much, Randy. Nice to see you again after a while. Thank you to all our panelists for the new information that has been shared today. Certainly, our team will look into those references. Allow me to share now more practical on-ground experience of the Philippines as regard to addressing gendered barriers and opportunities. We do know that the Philippines is ranked among the top countries all over the world in terms of better gender parity. But we also know that perhaps, as with any other country, there have been challenges due to the pandemic. We adopted this WHO and UNICEF framework when we started out with planning our demand generation activities for the Philippines, knowing fully well that there's context and a history of vaccine hesitancy due to the Dengvaxia incident, no, or the introduction of the Dengvaxia vaccine in the country. This framework was what guided our overall um, messaging, knowing that it is important to influence what the person thinks and feels, but also very clearly knowing that we have to be able to influence social processes along the way, and that too alone will probably influence the motivation. But to get the person from motivation to actually getting that jab will require us to fix some practical issues or operational challenges. That said, our team has to work closely with the operations team who are in charge of vaccination. And the operations team isn't just the national government, but for a devolved healthcare system like the Philippines, it also meant that a lot of the communication has to be calibrated dependent on the ability of the local government to do the operations. So we also do know that gender norms are a huge part of those social processes that we've talked about, and that's why the RCCE plan, or Risk Communication and Community Engagement Plan, would as much as possible try to address these. Um, the key barriers that we have identified are related to limited mobility due to a lot of domestic care obligation of women, low trust due to previous experiences with vaccination, lack of certain data, particularly sex, age, and disability aggregated data, and finally, limited tailored information. And I guess for the Philippines in particular, we actually have a more mature childhood immunization program, but not necessarily an adult immunization program. And then for the opportunities, we listed down that in the Philippines, women really are key decision makers in the family, as opposed to perhaps many other countries. Women have more informal community networks, and women are major drivers of the health sector. You know, most of our healthcare leadership, whether it's tertiary, secondary, or even primary care level are really women, particularly the community health workers, no, or barangay health workers. So, in implementing our activities, we looked at this intervention ladder for vaccine demand generation and incorporating this, no, the gender cognizant interventions and putting them into this spectrum. So obviously, when we were just starting out, we explored a lot of the persuasion box in our interventions, then slowly going up. No, of course, we wouldn't reach the compulsion box, which is legally mandating people to get themselves vaccinated, as what has been done in other countries for childhood immunization. But because the vaccines for COVID are under EUA, then this was not a part of the equation. So we started out with persuasion box, and this is largely communication work. No? Then slowly move into nudges, which required a lot of support from operations, then incentives, which will require more resources, and finally going into disincentives. No? So um, under the persuasion box, we did have typically, no, quad media campaigns, so spanning TV, radio, and social media. Then explored also some level of celebrity endorsement. We did have a lot of religious and cultural leaders that have been tapped to, say, issue out pastoral letters or even just videos to their communities that they are endorsing vaccination. Town halls. Early on, it was more online town halls. Then we slowly moved into face-to-face town halls. But interestingly, we also had to capitalize on the confidence that people had on the healthcare workers, as what Dr. Ken has mentioned. And in fact, the very first town halls that we did for COVID-19 vaccines were with healthcare workers, because clearly our data shows that people will believe, no, their healthcare workers, not some distant expert, but healthcare workers who they are familiar with. And so we had to make sure that the information was going to reach the healthcare workers, who in turn were the ones who will be convincing the citizenry to get their vaccines. We did also have media rounds, no, or what we would call kapihan. Again, especially during the pandemic, while social media was pretty predominant for most Filipinos, our data still shows that 70% of households in the country relied on television or media, traditional media outlets. And so part of the work was to work with media practitioners on how to report adverse events, for example, something that wasn't done um, well by the media community prior, in previous vaccine rollouts. And we wanted to make sure that they were going to be responsibly reporting any form of AFib this time around. There were also a lot of training done for our local government counterparts, because they did have, their own information officers and demand generators on the ground. And of course, we did have also a crisis com protocol. Then in the nudges part, we had examples of pre-scheduling, for example, to make sure that people will likely get their second dose. There were priority lanes, extension of vaccination time into the night and into the weekends, wherein people will probably not have work, anymore, and so they can get themselves vaccinated. Free shuttles or drive-through home visits, pop-up sites and transport hubs. So it's really bringing the vaccines as close to the people as possible. We also had the best practices playbook circulated to all local government units, citing best examples of other local government units. Then we had to move to another type, of work, which was incentives. For this one, we had the support of the private sector, who owned a lot of the restaurants and malls. So example here is this poster that encourages people to shop and dine, and they would get discounts if they show that they're fully vaccinated. Thereafter, we also launched a raffle promo called Vacunado Panalo for people, particularly senior citizens, who get more raffle tickets if they get fully vaccinated. Thereafter, more regulations were put in place temporarily to disincentivize people who are not vaccinated. This means not being able to access certain public places, for example, like malls, if you're not fully vaccinated. So with all of these, we did have examples of specific initiatives falling under the four main columns that I've shown you a while ago that responds to women's needs. What was glaring to us early on was that there was a specific segment of women population who weren't getting themselves vaccinated, and these were pregnant and lactating women. So we had to tap the support of our Philippine Obstetrics and Gynecologic Society, so the group for doctors, who take care of pregnant women, and had them help us do advocacy specific for pregnant and lactating women. There was also some fake news that were circulating at that time about men and women possibly being infertile as a result of the vaccination. So a part of the work was really promoting sexual and reproductive health literacy alongside COVID-19 vaccine literacy. We were also quite lucky because, as mentioned a while ago, healthcare workers in the Philippines are mostly women. And so they play a big part in influencing other women, women in their household, as sources of trusted health information. We also did know that women, particularly elder women, can be at risk, no, of having to stay at home, either for domestic work or because they're sick. And so tailored interventions had to be done for them, and this would include specific house-to-house or shuttled services towards the vaccination site. And then finally, we also had to undertake partnerships for specific types of women who, say, for example, in this case, this was a partnership with WHO and UP Diliman, University of the Philippines, specifically vaccinating homeless women and those victims of gender-based violence, providing a more customized, safer space for them to get themselves vaccinated. I mean, this is just to go through some of the persuasion materials that we had to produce, spanning informational types, so telling people about facts, then educational, and then, or sorry, the informational is more announcements, so when to get a certain type of vaccine, when is it already available. The educational talks more about the facts, the scientific facts that are laymanized. And of course, the motivational are the ones that, stories that tug people's hearts. So, as I've alluded to a while ago, we had to work alongside the local government units who were really rolling out the vaccination campaigns in their own locality. So, a lot of templates had to be produced, and capacity building activities were also done to support our practitioners on the ground. Now, where did all of these efforts lead us to? No? So, Dr. Ken started out with the numbers in the Philippines about Filipinos who are not going to get themselves vaccinated or who are uncertain about it. No? This was in May 2021. We're happy to note that after almost a year of hard work on the ground, of our demand generators, social mobilizers, healthcare workers on the ground, and the whole of society collaboration, we are at this stage, no? December 2021, wherein increasingly vaccine hesitancy has decreased. Not to say it is now disappeared, no, it has now disappeared. Of course, that will be a dream for all of us one day, but we're happy to say we've taken down a lot of the hesitancy with the help of whole of sector work. Even those who are uncertain are significantly less, and we did have positive, more positive sentiment about vaccination, and even boosters have more positive sentiments. So what is then the question? So did this translate to vaccination coverage? We wanted to say this could probably be much better. Our 72% target population coverage, definitely. No? So we have to work towards 80 to 90% total coverage for COVID-19 vaccination. But at the very least, we're happy to get to where we are now, considering the very, very negative numbers that we had to start with early in 2021. So what is clear to us also is that we have to move forward towards even more gender equitable rollout as we finish this stretch, this final stretch of vaccination. We have to be addressing sources of fears, hesitancies, and barriers of now smaller specific population segments, unlike before. It was bigger chunks of the population. continue analyzing apart from just collecting sex and age aggregated data, allocate now resources for gender responsive demand generation and communication, continue to capacitate our communicators, mobilize partners who can help us reach these specific segments, and also continue to choose the right communicators and multiply our champions. So that is actually, this is my last slide, really emphasizing that our work in the health sector is not ever going to be complete as long as the social protection mechanisms are also not available. And in wanting and in dreaming to close the gender gap, we have to make sure that the social protection schemes are also equally responsive, in addition to the health sector policies and programs. So yun lang po. Maraming salamat for this opportunity to share our work, and let's all work towards a healthy Pilipinas and a healthier Asia. Thank you.
Thank you, Dr. Bev. Thank you so much. Now we are opening the floor for questions and further discussions. And we have actually two questions here. The first one is from Najib, and apparently Jin has already responded. But Jin, would you want to elaborate further on the question Najib has raised?
Thanks, Randy. Yeah, it's a great question from Najib. And it's actually an area that I worked on before when I was working in Vietnam. It's really trying to address the poor representation of women in the STEM area, although I must say there are many countries who are really closing the gender gap on that front. But what I responded to in your question about how to change the representation or rate of representation on the technical boards is to start really at the very beginning with young boys and girls, about changing the stereotypes about who is actually an engineer, who's a mathematician, who's a scientist, and really promoting women in those roles. And I think that is one very concrete way to change negative stereotypes. And then to actually get women onto the technical advisory boards is using affirmative action. So creating quotas for the technical advisory boards. And just a reminder, these affirmative action is a temporary measure. And once there is more equity and representation, the culture will gradually change, policies will gradually change, and having those quotas could be removed because it'll be much more of a natural system. Thanks for that question, Randy.
Okay, thank you, Jean. And then there's another one. So I'd like to read this. It's for everybody, I think, anyone who would want to respond to it. Thank you to the speakers for your wonderful inputs in recognizing that vaccine supply and demand are of equal importance in the global problem that only 15% are fully vaccinated in low-income countries. In this context, how can ADB support sustainable vaccine production in the Asia-Pacific now and in the future? Is ADB considering supporting or investing in decentralized production of vaccines, such as regional hubs, so that we can meet current and future demands? In South Africa, for example, a regional vaccine hub for technology transfer expanding production is being set up, but currently faces limitation in terms of investments and intellectual property concerns. I think Dodo or Ayako. Dodo, you still there? You're muted, though.
Okay. First of all, I'd like to thank again the speakers. Really wonderful insights, globally, regionally, in ASEAN, of course, the Philippine experience, and I think really lots of lessons for us in ADB. We assure you we're going to pick up on the presentations you've done, and we'll really try to find ways in which we can support our countries, developing member countries, address gender concerns. Now, with regard to the question, I think this is really quite interesting. I think Jean, Gavi has always been championing vaccination, and now with COVID-19, now everybody is talking vaccination. Lots of countries that we're talking to are actually now talking about, for example, those that have not done rota, pneumococcal, and HPV are actually now talking about that. We should do all these vaccinations now. And that's good. That's something we need to sort of help countries to make sure that we sustain. Because in a sense, what COVID-19 vaccines have shown is the value of vaccination. You don't need to argue the case. And so now we need to reinforce that. But another thing that's come out, and I think this is something we have to grapple with, is a lot of countries are also talking about, I think this probably more province Asia, we're probably general to this South Asia as well, probably Latin America as well, that a lot of middle-income countries are now talking to manufacture their own vaccines. And frankly, when we talk to countries in Southeast Asia, Philippines is exploring that, Vietnam is exploring that, Thailand, Singapore, of course, Indonesia, so everybody. And I think there needs to be some dialogue now, not just in ASEAN, but globally. And I think this is a call out to Jean and hopefully tell your friends and Gabby. What do we actually start saying when we start sustainable vaccine production? Is it having all countries build their own respective manufacturing capacity? Or are we trying now to build on the COVAX and really get countries to sit down and we say, okay, these are the countries that will do manufacturing, and but you promise to make sure that the vaccines will always be available if there's going to be a next pandemic, an assurance that there will be no vaccine nationalism and all that. I don't think it's part of our gender discussion, but I think this has to be a dialogue, a conversation that needs to happen. Now, in addition to that, of course, we in the Philippines, we in ADB are supporting countries which have already been historically been strong manufacturers. So like in Indonesia has a very strong national manufacturer. Of course, ADB is very much involved with them to build up their capacity. That's why the in biopharma Indonesia is probably as good as Aspen in South Africa. And frankly, if there's going to be talk of regional vaccine hub, then this can hopefully address some of the concerns I just talked about of every country now desiring to manufacture, and that conversation where you have countries sort of assure and talk among themselves who's going to manufacture and how will they guide the supply. So I think I'll stop there.
Okay. Thanks, Dodo. Most countries in the Mekong are actually looking forward to living with the pandemic. So they're now discussing post COVID-19 modeling and scenarios. And I'm thinking that vaccine booster shots would be part of the daily routine. No, it's going to be a part of the yearly initiative to combat or to prevent further pandemics. Now, there are a list of questions. I would probably start first with Jean and Lavanya. COVID-19 vaccines were actually done very quickly compared to the other vaccines. No, the non-inclusion of or the failure to include women's issues in from research and development to clinical testing. Is this a usual occurrence? Has this been done to? Is this the same in other vaccines, or this is just simply happening under COVID-19 vaccine because they were quickly manufactured to address immediately the issue? Jean or Lavanya?
Lavanya, please go ahead.
You mute. We couldn't hear you, Lavanya. Okay, good.
Okay, thank you. I apologize for that. So like I was saying before, this is status quo, and the COVID-19 sort of approach has not disrupted status quo. So as I was saying before in the presentation, there have been calls. So we've come from a legacy of the male bias. Historically, it was just more convenient to use the male body as the reference point in medical research. We've come a long way. We indeed have, in terms of including people, including women in clinical trials, representing different types of women in clinical trials. But of course, as you rightly pointed out, this is just unprecedented time, the need for speed. And in the need for speed, I think a lot of people who may have been coming to terms with the idea of sex responsive practices, I feel, and many of my colleagues, we've been talking about this, that we feel that perhaps these were considered luxuries in this time that is time sensitive, and in this approach that was considered time sensitive. Now there have always been advocacy. There's always been calls from gender experts, scientists who work on the sex factors in specifically immunology and immune system responses and vaccine science. But again, I think this need for speed, it has relegated sort of the progresses that we've made. And even, I'll give you an example. So there have been numerous, in terms of talking about journal editors, many journal editors have signed commitments towards requesting for authors to provide more, gender analysis, sex analysis in the publication manuscripts as it comes to them. But of course, during the pandemic, when clinical trials came forward, I think none of that was actually enforced. And the key word here is it's enforcement. So I'll stop there and saying that, yes, it was business as usual. Nothing was disrupted, even though there were plenty of opportunities. And I think most importantly, the need to do differently.
Jean, would you want to add more on that?
No, I think Lavanya has covered it very well. I mean, I think the bias towards male bias in science and research is profound, and it would be good if COVID could have disrupted that, but it didn't. So it's something that we do need to address going forward. But as Lavanya has said, it's been like this for a while, so there needs to be some type of disruption.
Yeah,
thanks.
And I think it's not too late yet, because there are some countries who are still in the process of manufacturing. For instance, in Thailand, 6 more platforms are there are 6 platforms for manufacturing COVID-19 vaccines, and Vietnam is also exploring the possibility of manufacturing it. Probably would be a good idea to look into how they could integrate gender, women's issues, and of course, not just women, but the other gender sections in research and development and testing. Now, this question now is for Dr. Bev and Dr. Ken. You've talked about access to information. Apparently, when we were doing these preliminary preparations for the webinar, we found out that women have less access to information about the vaccine, mainly because one, the areas where they are far from the health facilities. Second, the use of digital information. More men are handier or more techy in terms of getting the digital information and getting themselves registered online. So that sort of hindered women's access to vaccine and vaccine information. Can you please elaborate on this one? Have you looked into this?
No, we haven't really looked into that, Randy. But you raised an important point, no? Access to technology is an important social leveler. But it comes with a double-edged sword, no? Access to technology may also mean access to wrong information,
Mm.
and the absence of information can also develop into doubts, and because of that lead to fear, and because of fear deciding not to engage in a decision. But in coming to terms with the public health crisis, really the decision is a risk benefit balance, where we need shall we say more learned professionals to look at it objectively, and view the temperature. Or I mean, would you rather have the disease and possibly have serious adverse outcomes, or get protected? So I think that's the dilemma that we see out there, where public health leaders have to make that difficult choice. But I guess Dr. Bep will have probably more the government perspective, and we can now hear from her.
Yeah.
Thank
Dr.
you, Sir
Beb?
Ken. Well, in our experience, based on actually our data, um, we know that women generally have higher health literacy. But interestingly, when the vaccine hesitancy data came in, it was actually higher for a particular segment, no, 55 and above women. And you can look at it as probably a barrier already, but perhaps that also tells you that maybe they're just more discerning, because generally they're the ones who's taking care of the family, making the decision. And so clearly, we had to make sure that um, the information or the materials that we release respond to these questions, no. And secondly, we didn't really have data on whether one had more access to information technology or the other, but what we were sure of is that consistently, even if everyone says most of their information source is social media, we can't put all our eggs on social media.
Mm.
We did have to really invest in still expensive television commercial, radio commercial, and as what Sir Ken said, really had partnerships with media practitioners to make sure that we're in their television or radio shows, have our experts rotating in all of the shows, and talking about all sorts of information, because this is really the way to reach them, no? Apart from actually on the ground activities, particularly when the cases have started going down. So I think there's just no replacement to actual relationship based communication, which social media can never do for you, no? And that's what clearly we thought we needed to do.
Okay. May I, in the addition to that, Dr. Bev, crafting communications focusing on women. If women in the first place, if there were women's issues that were not considered during the research and development and clinical testing, how can we craft communication on vaccine focusing on women's needs, if we failed from considering them during the manufacturing development phase in the first place?
I think the manufacturing phase is largely the biological part of it, no?
Yeah.
And the conclusions coming from when the FDA has decided to allow them to be used in the country, we know that they're safe and efficacious. No, as the communicators, we don't question that.
Mm.
There's an agency that's in charge, and in the Philippines, we did have more layers, no, of um, evaluation with our various expert groups until our HTAC. So when it reaches our part already, we just know that this is already safe and efficacious, and we can sell it to the people
Mm.
for them to actually use it. So from our end, it's really just making sure that we we speak to the audience that we intend to talk to. And you just need to simplify, perhaps, your messages. But I must also say that we did get help from professionals, though. You really needed them to be able to do this work, and it cannot be all health professionals, people just doing the messaging.
Thank you. Um, it has been discussed since from the very start about the role of community-based organizations, community health workers as frontliners in delivering information and at the same time getting involved in vaccine mobilization. I know in the Philippines we're tapping them, no? And I also think in some parts in Thailand. But how much work are we expecting them to do? Is there a need for further training, for skills development for our health workers and ensuring their sustainability to prevent further pandemics, particularly in the border areas? Yeah, Bev, you can start, and then maybe you can raise it with Dr. Ken.
It depends. No? It depends on the area. During the course of the pandemic, we were able to see that certain cities and provinces, their performance were really off the roof. No, they had even more creative ways for us to compare to what the national government has been providing them as templates. So you've seen people who or groups that have exceeded expectations. So in certain cases, maybe no, but for majority of the country, what we've really noted even naman before rollout of the vaccines is the way people define what health promotion or demand generation is very narrow. No? So the usual thinking is let's just print posters, give out brochures, that's it. No?
Mhm.
But it's more than that. It's more than in our joke. It's more than just saliva, no, that's needed to make health promotion work. And it means that you have to do a lot of community engagement, work with leaders of smaller groups. You need to invest, no, equally invest in the operations aspect of it. So I think yes, in general, capacity development will still be needed, and because of this initiative, I think we've raised awareness among local chief executives about how important it is for them to have a fully functional health promotion team, no? Not just an information officer who announces whatever event that's going to happen. That is not how sustainable health promotion is going to be.
Thank you, Bev. Dr. Ken,
Yes.
in your research, uh, did the health workers actually help in terms of addressing vaccine hesitancy or helping out ensuring that women are, getting jabbed?
All right. No, in our research, that we did not purposefully look into that, but it was looking into the trust index, how
Mhm.
well you trust among those 5 countries, health workers and health professionals. That's what we found out. But I can cite my own experience as a volunteer in one of the vaccination sites. Earlier, Dr. Beverly showed a picture of the UP, University of the Philippines, where we did voluntary work on behalf of the Quezon City local government. Boy, the amount of investment in getting the people involved with vaccination, giving them protocols on how to respond to particular questions, uh, going through the accreditation process, and then dealing with every step of the way information at different sites. They were diligently followed, and that was because we were rolling out something very new. The amount of social preparation was quite invested, and as a result of that, we were able to communicate with women, in particular those who are afraid to be vaccinated. I mean, the protocols at the earlier part calls for, because we didn't know, the protocols called for women only working in the health front lines who may
Mhm.
be at higher risk. But later on, as Dr. Beverly indicated, consultations with our own professional organizations like Obstetrics Society um, found evidence to say that in real world evidence, it is relatively safe and it is okay. But even despite that, we offer the women a chance for informed consent and if they want to take it or not. So that's the level of effort and respect we have provided. Even I know that these things are not perfect, but that there was a sincere attempt to localize that kind of conversation.
Okay. Another question, Dr. Ken.
Hmm.
May I read this question first? When using the concept vaccine hesitancy, there is
Yes.
a tendency to put the blame burden on individuals.
Mhm.
And there are many other factors, determinants to this, such as social, technical, political. I appreciate the definition you shared that describe vaccine hesitancy more as people
Yes.
unsure, and that it can also be viewed as a spectrum. Can you please share the source for the definition, and are there other definitions of this concept?
All right. Thank you for your question from our participant. I answered it there, but I'll maybe verbalize it. The definition that I borrowed came from the Asia Pacific Immunization Coalition. So it's a body of experts who came together. Indeed, the person who asked the question is correct. It is an evolving spectrum. And he is also correct, or she is also correct by suggesting that you can place the blame on the person because the decision is really a product of social determinants, political, social, information, what your health advisors and professionals have told you. Mind you, we also experience local Filipino doctors telling their patients not to get vaccinated.
Yeah.
We have seen that they are in a minority, but can you imagine the kind of confusion that will create going against government messaging? So, am I aware of other definitions? Well, no, but I guess there are many other definitions out there on vaccine hesitancy. I think we need to be more sensitive that they are in fact sitting on the fence. They're not anti-vaxxers. There are people who are sincerely looking for information to guide them into making informed consent. And I think we need to make an effort to bring them in rather than to lump them all together as anti-vaxxers, for which they are not.
Okay, thank you, Dr. Ken. Just one last question from my end, and then I'll sharing another information later on. I think either Jean, Lavanya, or Bev and Ken, are the countries strong in terms of monitoring post-vaccine uh, post-vaccine effects or adverse effects following immunization? Are the countries strong, particularly Southeast Asia? They're strong in terms of monitoring infections or illnesses after the vaccine, particularly on women.
Randy, may I offer first
Sure.
take on this? No?
Okay,
All right. Thank you for that question. Countries have varying levels of maturity in terms of soliciting or getting patient or health professionals report. AEFI refers to adverse event following immunization. There is such a program and protocol, and there has been some improvements and iteration in how WHO have rolled out that program. This information that you collect, as I said, varies countries to countries. It is the determinants are how strong is your drug regulatory agency in promoting such capture. In the case of COVID vaccine, this was there was a system. It was delegated to local government and those people involved with vaccination monitoring. We didn't see a perfect system, but there are reports. In fact, in the Philippines, we're one of the top 5 global reporting of adverse event following immunization. And the reason why I say that is because these reports are consolidated in a WHO agency called Uppsala Monitoring Center. It's an international collaborating center for drug monitoring, and they are now putting together the vaccine reports around the world. One can look at the vaccine adverse event as individual cases, but you cannot make any causality or attribution without looking at the big picture, where then you have to calculate attribution. The only way to do that is to pull the data country to country so that you could make a proper guidance. And from what I found is that yes, there are subtle differences among the vaccines and I think our previous speakers have very greatly explained this, that there are subtle differences with the different kind of vaccine. And the important thing is not to take that for granted, monitor it, and then come up with a conclusion whether the public benefit outweighs these individual risks, and how did we could identify people who may not have to take this vaccine and take another form of vaccine. I think that's an important consideration. So vaccine safety, if done properly and communicate properly, will inspire trust. Not doing it will create a level of mistrust and conspiracy building. Okay. Thank you for that opportunity to explain this.
Thank you, Ken. Jean, Lavanya.
I think Dr. Ken has covered it extremely well, and he's much more aware of the situation in Southeast Asia than I am. So I think that's a great response that he shared.
Okay, I'd like to share this. In Thailand, the government closely monitors and looks at each case of alleged illness resulting to COVID-19 vaccination, and they're given incentives for reporting, and then they come up with clear reports after the cases have been investigated, and there've been, I think, 2 or 3 cases that were actually cited as complications because of the vaccine. No, sadly, we don't. I haven't heard of that in the Philippines or in other countries, but we've heard a lot of rumors. For instance, that people died of heart attack, hypertension because of COVID-19, and that's in the Philippines. So, Bev, do we have that monitoring in place?
Sorry, Randy, can you repeat it?
Do we have a good monitoring of adverse effects following immunization, particularly in the case of COVID-19 cases?
For vaccines, definitely, no, it was one of the things that was earlier set up, as mentioned by Sir Ken a while ago. So we do have a national adverse events following immunization committee, and there are regional committees also in place. So from top to bottom or bottom to top, people have been trained. So there will be initially, when there's a report of an adverse event, then you will have investigation that will be ongoing at the regional level. And then if they will have difficulty deciding on the case, then it goes to the central office level with the national adverse events following immunization committee.
But have we had reports that are already been investigated and found out true?
Definitely, no. So the universe of reported cases are actually published in the FDA website. People who report online are actually already there. A portion of that is elevated for specific investigation. Syempre, those who a majority of those who report adverse events are mild adverse events, no, but they're still
Okay.
adverse events nonetheless. So it's really the serious and critical adverse events that are followed up with full-blown investigation.
Okay. Thanks so much. Anybody else who would want to share any closing remarks? Jean, Lavanya, Ken, and Beverly, before we go to the summary. Any last words? Last advocacy? Lavanya probably would have a lot to say. We've discussed this earlier before during the preparatory meeting.
Randy, may I start?
Yep, go.
Yeah, I would just like to plug that I think, all of us, there does seem to be some respite in the pandemic, and it's an opportune time to really reflect on how countries organized around the pandemic and what we could do better. And I do think the social aspect needs to be considered in terms of how we address the hesitancy and really taking this human-centered approach to designing our vaccine programs. And as you were mentioning, you know, COVID-19 vaccines will be part of our life course approach in vaccines now. So each country program will need to revise, because our routine immunization is very much centered on the child or even below 2 years of age. So I think this is an opportunity really to develop a strong life course approach for all vaccines, making sure HPV is much more prominent in the vaccines that are offered, that we address adolescents at an early age to make them understand the importance of vaccines and how they're life-saving, and they're needed for young children as well as adolescents now. Thanks again for the opportunity to speak with you. Bye.
Thank you, Jean. Thank you so much. Vanya? We can't hear you.
I think it's the mic. Do you hear me now?
Yeah.
Okay.
Clear.
Thank you. I'm going to echo what Jean has said. You know, look, the pandemic has woken up a lot of people who have not been discussing vaccines, health equity, health security. You know, it's front and center now. And I think, you know, with the health sector, we perhaps in the early days were not used to so much attention being placed on vaccine outcomes and that sort of thing. But, you know, here's an opportunity. And somebody mentioned the word build back forward, which is, you know, is such an interesting concept. I think that's ADB's language of, you know, what we do next in this endemic phase as we move ahead. And Randy, as we were talking prior to this call, you know, ADB as a funder who's assisting or working with regional stakeholders to develop vaccines, to develop manufacturing capacity, to develop the science capacity as well. Perhaps, you know, I'm putting it out there, perhaps, you know, it can be a condition of the loans, of the funding, of, you know, the negotiations and the partnerships that, you know, sex responsive sort of approaches are integral and integrated into those terms of references and processes. So I'll leave that with you to take forward, and I'm happy to have further discussions of, you know, what specific actions can be strategized.
Thank you so much, Lavanya. Ken?
Thank you, Randy, for this opportunity. Just have a very quick two-statement here. No? I view health as a collective responsibility. It's everybody's business. So I am asking different stakeholders to pay attention to building and strengthening your own local health system, because that's an important way to build trust in government and to the health delivery system. Secondly, we need to invest more in terms of patient literacy in health. And in so doing, it will also elevate the understanding of women's equity in health. And I hope that we collectively take that very seriously. Thank you, Randy.
Thank you so much, Ken. Bev? Nice to see you again.
Yes, thank you. I think from our end, partnerships, no? Public, private, national, local, CSO, government, all of these are going to be very important because government alone can't possibly do everything. And we survived because of meaningful partnerships with our key stakeholders. And we know that this is what's going to allow us to sustain our gains in health promotion, particularly when we start rolling out initiatives outside of health facilities, no? Meaning schools, workplaces, communities, and other settings. So thank you.
Thank you so much. Is Samantha still here, Sam?
She left na po, Sir
Okay,
Randy.
okay, thanks. This is you know, this is an eye opener, and our previous discussion with Lavanya is that the future forthcoming webinars, we will ensure that gender and women dimensions will be included, because we will be doing something on the elderly. We'll be doing a webinar on digital health, health communications, and community-based institutions and CSOs. So we will make sure that we would integrate a session or a topic there on gender and particularly on women's issues. So we will assure you that from our end. And before I turn it over to Dodo, I'd like to thank everybody. I'd like to thank the team also who has worked on this one. Rusette, who was actually the one who initiated discussions with you, unfortunately, is still in the hospital. And we're praying that she gets well soon, no? And join us in our future webinars. So thank you again so much. Maraming salamat. And Dodo, for summary and next steps and closing.
So allow me to thank everyone again, and really the challenges that everyone is giving, from what Jean is saying. The fact that in COVID-19, most of the people sitting at the table were men. I think that's something that should be addressed. Lavania's point about a lot of the research on vaccines, medicines are mostly for men. Lack of data, it's a good thing that now we have disaggregated data in a number of countries, but we saw that problem also in Southeast Asia. We started mobilizing support for vaccines. In Asia and the Pacific, the lack of disaggregated data, lack of recognizing the problems, some of the unique problems. So in a sense, non-responsiveness to the needs of women. What Southeast Asia is doing sorry, I think I got kicked out. I'm still connected now. Can you hear me? And finally, of course, the great experience of the Philippines in vaccine comms and how they have actually integrated gender concerns in work on that. So we look forward to working with all of you, with Gavi, with Lavanya, with Ken, with Ateneo, with Bev. Of course, we've been supporting DOH. And of course, we thank everyone who's in the audience, and looking forward for further discussions and collaboration. Okay, thank you, everyone. Randy.
Thank you. Thank you so much. It's been a wonderful afternoon with you, and I hope to see you again. Stay safe, everybody. Maraming salamat.
Thanks and bye.
Bye.